Thank you for joining in this session. And in this session today, I hope to discuss the what, why, and when of whole genome sequencing. What is whole genome sequencing? Why and how should we do whole genome sequencing? And more importantly, in what clinical settings should you do whole genome sequencing? Before I start my talk, I think I'll go back a bit into history. And there's a history of around 50 years before time. And this is when this engineer, Sir Godfrey Hounsfield, invented this contraption which changed the practice of clinical medicine. And to give a context, clinical medicine at that point of time used to rely extensively on what we call as exploratory laparotomy. That means that if a patient had, for example, an abdominal pain, which is intractable, which is not going away with medication, then a surgeon would typically open up the abdomen to really see what is really wrong inside the abdomen. And many often, patients would die because of this surgery. Now, what Sir Godfrey Hounsfield has invented was his contraption for the first time allowed clinicians to peek inside the human body and in three dimensions, as if you could really open up the body, but in a very non-invasive way. And that really changed the practice of medicine as we see today. And what he invented is what we call as a CT scanner. It is widely accessible and affordable to doctors and patients alike. And that really changed the practice of medicine as we see today. Explorative laparotomies are something of the past and rarely used nowadays. I brought this up because early this century, approximately 20 years ago, humans for the first time were not just able to peek into the human body, but also peek into the blueprint of every cell that forms the human body. And that is the genome sequence. And this large, massive, multi institutional and multi country collaborative effort is estimated to have encompassed around 20 organizations from around 6 different countries and is estimated to have costed approximately $3 billion to sequence and provide the first blueprint of the human genome. And this also provided the early assessments of the genes in the human genome and, more importantly, the differences in the human genome. And this is more so relevant in a country like India because India is a very large country. Today encompasses almost a sixth of humanity on world. It is very large. It's 1.4 billion people. And more importantly, unlike other large countries around us, it's also extremely diverse in terms of very large and small endogamous groups with multiple different ancestries. It's estimated to have around 4,000 odd endogamous groups. And more importantly, unlike many countries across the world, we still have a close knit family structure and largely undisplaced by global events in the last few centuries, including world wars, massive wars, and famines. India was largely undisplaced for many generations altogether. And everything in genetics starts with a human pedigree. And there are families in India who can trace not just 3 or 4 generations of pedigree, but in many ways up to around 50 generations of the pedigree. But unfortunately, though we are a very diverse country and encompasses a sixth of the global humanity, genetic information from India is poorly represented or underrepresented in global genomics initiatives. So in 2009, with my colleague Sridhar, I was very fortunate to have been part of the first genome initiative in the country, which sequenced the first human genome way back in 2009, and which was also announced by the Honorable Minister in the Parliament. Now, what is whole genome sequencing and how is it very different from the other tests that we all know? So there are very different kinds of tests today that we use. One of it is genotyping, where you know the genotype, like for example, sickle cell anemia. You need to just look at that particular genetic variant, the HPS variant, and then therefore you could make a clinical assessment based on it. And you use a variety of techniques. This includes sequencing on one part. This includes genotyping on arrays on the second part. And this really looks at a very, very small proportion of the human genome, typically bases or hundreds of thousands of bases at the max. Then we have whole exome sequencing. Whole exome sequencing sequences using the capture method the protein coding regions of the human genome, or the exons in the human genome, and this roughly encompasses around 1 to 2% of the human genome. On the other end of the spectrum, you have a whole genome sequencing. That means that you could cover or sequence 3 billion bases of the human genome, and therefore it is something that we can sort of think of as near complete sequence of the human genome. And in terms of the clinical applicability, while whole genome sequencing is as clinically applicable as many other disorders, it is also very flexible, that it has a wide variety of discovery potential, that you can identify new genetic variants, new diseases that was previously uncovered. All the other techniques are largely reliant upon the knowledge, the prior knowledge and evidence about human diseases and human genetic variants. In clinical settings, we indeed use a variety of genetic tests, and these genetic tests looks at a variety of different resolutions of genetic variations. On one end of the spectrum, what we have is chromosomal abnormalities, numeric abnormalities or translocations or deletions in the chromosome. And we use a typical approach, what we call as karyotyping, traditionally widely used to look at chromosomal genetic disorders. And then, of course, you could use FISH when you're looking at structural variations, especially when you want to sort of stain specific regions in the chromosome and sort of look at it under the microscope. And this is also widely used in clinical settings even today. Then there are different kinds of genetic variations, like, for example, repeat expansion disorders, which is assayed using repeat PCRs. Then you have deletions and copy number changes, which could be assayed using chromosomal microarrays. Then you have small insertion deletions and structural variations, which could be accessed, small variations and breakpoints, which could be accessed by sequencing approaches. And then, of course, single gene disorders, which could be today done on either a Sanger sequencing or, in some cases, a panel sequencing. So you have wide variety of resolutions of the very different tests. Each of these tests have its own turnaround times, its own complexities, its own expertise required to sort of implement the testing. Now, what whole genome sequencing encompasses is all these tests in one single test. In many words, this could be thought of as a convergence of genetic tests. It can do all of these genetic tests and also provide much more information than all of these tests put together. Now, I will sort of exemplify this in one example from our past studies. This was done as part of the Guardian Consortium in my previous institute at the CSR Institute of Genomics and Integrative Biology. Now, this child was referred, whom we call as Ashi, was referred to us by the All India Institute of Medical Sciences as a 9-month-old baby with a small head, microcephaly, small eyes, with failure to thrive, and of course, with the labs suggesting an elevated lactate and a pyruvate. Now, all this constellation of symptoms sort of point to a mitochondrial genetic disorder, and the provisional diagnosis was Leigh disease or neurometabolic disorder. And there's a clinical scoring criteria, which is the emergent scoring criteria, and the score was pretty high, sort of suggesting that the clinical diagnosis of a mitochondrial genetic disorder. Now, when you look at a mitochondrial genetic disorder, the first thing that you do is to do a cascade testing. You would want to sequence the mitochondria. And fortunately, at that point in time, we were one of the few labs in the country which were doing mitochondrial genetic sequencing, and one of the first labs in the country offering next generation sequencing for mitochondrial genetic disorders. So we did sequence the mitochondria, but unfortunately, after extensive analysis, we could not yield any genetic mutation which could sort of suggest a mitochondrial genetic disorder. And typically, in a cascade screening approach, you would go back to the next test, and the next test here is a whole exome sequencing. And we did indeed do a whole exome sequencing. And unfortunately, even in this particular situation, we could not get a pathogenic genetic mutation, which can sort of suggest a diagnosis as a mitochondrial genetic disorder. We did a whole exome sequencing because a significant number of genes in the chromosomal locations do encode for mitochondrial proteins, proteins which can go into the mitochondria and can influence the function, or are important for the function of mitochondria. Now, fortunately, at that point of time, we were also doing whole genome sequencing. So we did a whole genome sequencing of this child, the proband. And what we found was a deletion which encompasses 3 genes one of which was quite important in the mitochondrial function. But this large deletion of around 140 odd kilobases was not documented before, uh, and therefore this could be classified as a variant of uncertain significance for lack of evidence that the genetic deletion indeed causes the disease. Now, when you come across a VUS, or a variant of uncertain significance, according to the ACMG and the AMP guidelines and the scoring scheme, there are largely three things that you can do to improve the evidence base. One of it is to do an extended family pedigree, to sort of look at segregation in the extended family pedigree, or if of individuals who are affected versus individuals who are unaffected. Number two, you could look at the population frequency of these genetic variations. And if the population frequency of the genetic variation is extremely high, you could classify them as benign. And more importantly, the highest score is probably given by adding functional evidence to that particular genetic variations. And to do that, what you do is to do a functional study. And to do a functional study, you need to step back into the lab and sort of make the exact phenocopy of that particular genetic mutation to understand what does it really do to a cell. So to come back to this particular case, what you see here is the first three rows. The first two rows are the parent, and the third row is a proband. And what you see here is very peculiar. The proband has a homozygous genetic deletion, while the parents do have a heterozygous deletion, non-overlapping, rather overlapping at around 140 odd bases. They're not the same genetic deletion, but they overlap across the same locus of around 140 odd genetic deletion. So roughly that would mean that this proband essentially has a compound heterozygous genetic deletion with a common region of around 140 odd kilobases, apparently looking like a homozygous deletion. But in fact, it is a compound heterozygous deletion. So two alleles have two different deletions with a common region of around 140 kilobases. Now, of course, like all families, they would want to have a second child, a third child for that matter. And of course, the child, after around 10 months, was conceived. But of course, the child also, that's a fourth row out there, also had this genetic deletion. Now, in many cases, you would not want to do a prenatal testing for a child because you don't have, and you should not, in fact, because you don't have evidence to suggest that this variant is indeed pathogenic. So, to cut the story short, what we essentially did in the intervening 9 odd months was to essentially step back into the lab and essentially prove that this deletion is indeed pathogenic. And this work was done in the lab of Dr. Sridhar Sivasubu. And essentially what we did was simple. You could isolate fibroblasts from the child, the proband. You could culture them and do a mitochondrial assay. And the mitochondrial assay indeed showed that it is a mitochondrial genetic disorders. And this assay involves introducing chemicals one at a time, which can block very specific pathways in the mitochondria, and then look at the mitochondrial function in terms of the electron transport chain. The other approach is essentially go back to a model system, and the model system that we used here was zebrafish. You could create the exact gene deletion in zebrafish to see what did really happen to the zebrafish. And what we showed is that the zebrafish indeed has a mitochondrial genetic defect. And by proving that this is a mitochondrial genetic defect, what next step you can do is to build an MLPA test, which is a cheap and affordable, accessible test and a scalable test, which can now be used for screening not just of the family members, but also the extended community, because they come from an endogamous community. Now, in 9 months, we could complete this, we could make an MLPA assay, and of course, we could prove that the fetus was abnormal because the fetus also had the compound heterozygous deletion. Fortunately, the family today has 3 apparently normal children who are born out of genetic diagnosis and prenatal screening, that they can have a very fruitful and happy family. Now, of course, this is one case. You might ask, is there evidence that whole genome sequencing is better than traditional standard of care testing? The answer is probably yes. This is a very recent study from Canada, which evaluated around 100 odd patients. And what they suggested is that while a standard of care genetic testing provides around 24% agnostic positivity, a whole genome sequencing can increase this to approximately around 41%. That's significantly large. And of course, there are other studies like this one very recently, which was reported in the New England Journal of Medicine, which evaluated around 800 odd families from diverse medical conditions. And what they suggested is that compared to a panel or exome sequencing test, the additional diagnostic positivity is around 8.2% in a very wide and diverse cohort of different ethnicities and different disorders. And multiple evidence from multiple different labs sort of suggests this to be concordant by additional diagnostic positivity of around 10% across multiple different cohorts. Now, what is the real application of whole genome sequencing? And one of the applications, I believe, is to do newborn screening. Now, newborn screening today is an enterprise which is run across the world. Many countries do it, many states, including the US, does it. And there is no real consensus on what should be included in the newborn screening panel. For example, if you look at the United States, there is a consensus in terms of a uniform screening panel, which today encompasses around 37 different conditions. But even within the US, there are different states which has implemented different panels or different genes, for that matter. These are not genetic testing for all cases, they're largely biochemical testing. And roughly, it has been estimated that 1 in every 300 to 1 in every 500 children born would have been positive for the RUSP, or the recommended uniform screening panel. Now, why do people do screening? People do screening because these are conditions which, if you can diagnose very early in the neonatal stage or the newborn stage, you can treat them very effectively. And therefore, you could screen for these conditions at birth and institute early treatments so that the child can have a perfectly normal life and can contribute to the society as normal and productive individuals. If you ask me how prevalent are treatable genetic disorders, there are many estimates. One of the estimates is that approximately 1 in around 182 newborns across around 390 or childhood onset treatable disorders are today treatable. And that is quite large. And in many ways, I think this is an underestimate because the prevalence of many treatable genetic conditions are not really known. And of course, there are population-wide or even subpopulation-wide differences in the prevalence of many of these conditions. But 1 in 182 is a quite significant number to be looking at. Now, how do we decide what to screen for? And broadly, the decision on what to screen for should be based, I believe, and based on 4 things. One, it should be prevalent, or in other words, the numbers needed to test should be small. Second, it should be penetrant. That means if you identify a genetic variant, a pathogenic genetic variant, then the likelihood that that genetic variant would indeed cause the disease should be very high. There should be evidence of actionability. In other words, once you diagnose the patient, the evidence to go ahead and act upon the diagnosis should be extremely high. And more importantly, it should be a treatable genetic condition, not just treatability, but with an affordable and accessible treatment option. You don't want to diagnose a lot of children who are treatable apparently, but would be absolutely unaffordable to treat. The best examples are, for example, spinal muscular atrophy, or for that matter, the new sort of gene therapies, which are extremely unaffordable to be sort of screened for in a neonatal stage at a population scale. Now, of course, there are multiple genomic newborn screening panels currently available, and there are multiple programs across the world who have been using genomic testing for newborn screening. There is broadly very little consensus between these, but yeah, as you see here, around 53 odd genes which are broadly screened by almost all newborn screening programs. And this is very understandable because the treatability and affordability is context dependent. There are some countries which are rich and can go to any extent to treat rare genetic diseases. But then, of course, there are countries who are poorer and who would only want to include prevalent treatable disorders which can be treated using an affordable treatment option. Now, when we think about genomic testing for newborn screening, what we need to think about is 4 points. One, what is the efficacy? What is the accessibility and affordability of the test and the treatment option? Are we trying to diagnose more than what we can treat in terms of over treatments? And of course, there are some ethical gray areas, like, for example, off-label use. And then the portability of the genetic variations to additional family members, not just the parents, but also offsprings and additional blood relatives in the extended community and the extended family. But of course, you need to keep in mind all of these. And beyond this, of course, there is a wider application of whole genome sequencing, not just in the diagnosis, not just in screening, but also widely in oncology. And in oncology, with a large number of newer targeted therapeutics available, what we call as precision oncology, there are also not just variations which are important, but also combinations of variations and scoring methodologies which come in important, where you need a broader panel. For example, if you were to look at tumor mutational burden, or if you want to look at HRD, you need to have much broader panels which can encompass not just genetic variations, but also combinations of genetic variations, which could be, or types of genetic variations which could be scored together. And whole genome sequencing, therefore, becomes an extensive sort of mapping opportunity in terms of diagnosing patients for cancer, but not just that, but to also prognosticate them and to offer them precision therapies. Now, what does evidence say in terms of use of whole genome sequencing in oncology? Of course, there is a very recent paper from the UK 100K program, which sort of suggested that around 16% of all people with the whole genome sequencing become eligible for currently approved therapies. And that is a significantly large number, because that's approximately 1 in every 6 individuals who have received a whole genome sequencing, and a person with cancer who have received a whole genome sequencing would have an actionable genetic variation which can be treated using an approved approved therapeutic regimen. And of course, there are multiple other studies. For example, this one in Korea has sort of suggested that approximately 40% of individuals would have an actionability based on an on-label drug which is approved by the authorities. Now, as you see here, there's a discrepancy in the numbers of positivities and numbers of people who could be actionable based on the information. And this is very well understandable, because the actionability and the prevalence of many of the genetic variations are sometimes population dependent. Or in other words, there's a disparity in the prevalence of variations, and therefore the actionability of variations across different populations. The other thing that you need to keep in mind is that a whole genome sequencing is for a lifetime. The germline genome is pretty constant from the day you're born to the day you are dead, because practically all the trillion odd cells that we have is produced from dividing a single cell. And essentially, this single cell has the genomes that come from the two germ cells, the ovum and the sperm, from both of our parents. And from the day you have an embryo, that genome pretty remains constant, with minor exceptions of adding genetic mutations by mitosis, but largely remains constant. And therefore, the best time, of course, to do a whole genome sequencing is to do it at birth. But of course, that doesn't mean that people who are born and people who have grown up like you and me may not be accessible and available to do whole genome sequencing. The answer is no. Probably we would also benefit from whole genome sequencing. The more important thing is that at different points in our lifetime, we would want to ask very different questions, and whole genome sequencing can answer all of them at that point in time. For example, when you're a newborn, you would want to answer very specific questions like, do I have a treatable genetic condition? But of course, when you're in childhood, you would want to look for other disorders, like, for example, hearing loss. You would want to look for example, autism spectrum disorders, learning disorders, neuromuscular disorders, so on and so forth. Early adulthood, you would want to look for things like familial hypercholesterolemia. You would want to look at cardiac channelopathies, because these are late onset manifestations. You would want to look for example, MODY, which are all prevalent genetic conditions. Much later on, you would want to look for example, inherited cancer syndromes, because that's typically during the middle age that you sort of manifest these conditions, and you'd want to look for whether you have an inherited cancer syndrome so that you can have targeted screening approaches. And in old age, of course, you could want to diagnose malignancies. You would want to look at neurodegeneration. Many of them are now genetically determined, and treatments are also genetically determined. And of course, there are points in time where you would want to look for carrier screening. When you want to sort of have your family, you would want to sort of look for whether you're a carrier, and whether your spouse is a carrier for a genetic disorder. It could be a very prevalent genetic disorder like thalassemia, or it could be a rare genetic disorder like Duchenne muscular dystrophy. And of course, then you would have a wide variety of applications in pharmacogenomics, because from middle age you start taking medications for one of the other prevalent common disorders. And for a wide variety of these medications, you do have pharmacogenomic variants. To give an example, around 60% of Indians do have pharmacogenomic variations for antiplatelet drugs. Around 30% of individuals would have a pharmacogenomic variant for statins, so on and so forth. So it largely would affect individuals and their health. Whether you are a newborn, whether you are an adult, at any point of time, you could do a whole genome and you could glean very valuable information from a whole genome sequencing. So broadly, what I would want to give the impression is that genomics or whole genome sequencing is not just for the diagnosis. It could also extend to early screening right from birth in terms of germline risk for genetic conditions. Early on, you would want to look for treatable conditions. Later on, you would want to look at preventable or screenable conditions. So the applications of genomics in clinical medicine is quite pervasive. And while we need to apply genomic medicine or whole genome sequencing in clinical medicine, what we need to always keep in mind is that we need to also make this data accessible for re-evaluation and revisiting with the continuously emerging evidence for genetic variants. And therefore, you need to have a system which is prepared to address the health outcomes, prepared to address the psychosocial outcomes, uh, prepared to address the cost and cost effectiveness in terms of implementing not just the sequencing approaches, but also the revisiting and reanalysis approaches that could come in days to come. And we were fortunate to have been able to create one of the pilot experiences like portability of genomic information using what we call as a genome card, which is essentially a credit card type of plastic card, which doesn't have any information, but provides you access or your clinician access to the evidence at that point in time, not your genome sequence. It can provide you evidence that can be actionable at that point in time. So in other words, this is a secure, scalable, privacy protected, and clinician enabled point of care evidence-based system where clinicians can access evidence on your genome to act upon. And of course, there are many other issues that we need to address before this becomes a reality. And the first of it is, of course, ethical in terms of consenting process and, of course, reconsenting in some cases. There's, of course, legal issues because there is a potential for harm, especially if you don't have the legal provisions to protect individuals from discrimination based on genetic information. Many advanced economies do have legal provisions to prevent discrimination, like, for example, the GINA Act in the US. And many countries which don't have such legislation need to urgently implement such legislative options so that you can protect individuals from being discriminated, for example, for insurance or for employment. And then, of course, there are implications in terms of therapeutic interventions, especially for late onset disorders. And more importantly, there's social issues when, for example, a carrier status is sort of synonymous with the community or the population, which is a high prevalence. And then, of course, you could have discrimination based on the prevalence of genetic diseases between populations or between communities. And then, of course, there are issues of long-term data management issues because I sort of said that genomes are for a lifetime, and therefore you need to maintain the data and make it accessible for reevaluation and revisiting all throughout your lifetime. So before I close, there are a few take-homes. The first take-home is genome sequencing is becoming quite affordable and very soon will become one of the mainstays in clinical implementation. Genome sequencing at a personal level can enable disease diagnosis, can enable disease prognosis, and in many ways can also enable precision treatments. And aggregated at a population level can provide very useful insights into population scale genetic diseases and a very valuable evidence for population scale decision making for public health. Many of the genetic diseases are indeed very prevalent. In fact, 1 in 10 individuals who are apparently normal do have a genetic disease. Many of us do not diagnose it very early on, do not act upon it very early on, but nevertheless, they would manifest throughout our lives. And therefore, genomes are for everyone. Genomes are not just for patients with rare genetic diseases. Genomes are not just for patients with cancer. Genomes are for everyone. And therefore, genomic sequence is also for a lifetime because a genome is constant from the day you're born to the day you're dead. Thank you very much.